This video summarizes one of the papers that evaluated the effectiveness of Mulligan's mobilizations with movement. This randomized controlled trial evaluated the long-term efficacy of mobilization with movement on pain and functional status in patients with knee osteoarthritis. It was authored by Aishwarya Nigam, Kiran Satpute and Toby Hall and published on the Clinical Rehabilitation Journal, in 2020. Pain and disability associated with knee osteoarthritis is the second most common musculoskeletal disorder with overall prevalence of 28.7%. Various guidelines for the management of knee osteoarthritis include lifestyle modifications and exercise. Exercise in particular has been shown to provide sustained benefits on pain and disability. Manual therapy can also be used as part of a multimodal conservative management approach for knee osteoarthritis as it has the potential to modify symptoms, although the exact mechanism of action are unclear. Differing to traditional passive manual therapy techniques, Mulligan manual therapy includes mobilization with movement. This active form of treatment has demonstrated successful outcomes in the short term as well as preliminary evidence in the long term in patients with knee osteoarthritis pain. The purpose of this study was to examine the long-term efficacy of mobilization with movement in addition to usual care comprising exercise and heat in patients with symptomatic knee osteoarthritis. Consecutive subjects with knee osteoarthritis presenting to the physiotherapy outpatient department were recruited into this trial. A diagnosis of knee osteoarthritis was made by an orthopedic surgeon based on the American College of Rheumatology clinical criteria. Subjects diagnosed with a score of between 1 and 3 on the Kellgren and Lawrence osteoarthritis scale were considered for inclusion in the trial. Subjects were assessed for eligibility based on inclusion and exclusion criteria. The inclusion criteria were as follows: either gender, between 50 and 70 years of age with knee pain of duration greater than 3 months and intensity between 4 and 8 on a 10 cm visual analog scale at the time of presentation. They were required to be able to stand up independently from a chair and to be able to lay prone. Subjects were excluded if they had recent lower limb fractures, any neurological condition, contraindication to manual therapy, post-traumatic knee osteoarthritis, total knee arthroplasty, uncontrolled hypertension, radiating leg pain and body mass index over 30. 40 participants were then randomly and equally allocated to a group receiving mobilization with movement plus exercise and moist heat, experimental group, or a group receiving exercise and moist heat alone, control group. All subjects received moist heat for 15 minutes. The exercise program was designed to improve muscle strength of the hip, knee and ankle musculature. Exercises included pelvic bridging, resisted knee flexion and extension, mini squats and heel raises. Exercises were progressed from 15 repetitions times 3 sets to 20 repetitions times 5 sets as per the capability of the subject. Recommendations were made for the patient to undertake similar exercise at home. In addition to exercise and moist heat, subjects in the intervention group received mobilization with movement prior to the exercise program. The therapist applied a pain-free manual sustained glide force to the proximal tibia with counterforce on the femur, and the subject was instructed to move their affected knee in the symptomatic direction, as far as possible without pain. The direction of glide which had the most beneficial effect on improving pain-free range of motion was chosen for the treatment. If the subject was able to achieve end range without pain, pain-free overpressure was applied by the therapist. The technique was progressed to weight bearing once full range was achieved without pain in lying. 3 sets of 6 to 10 repetitions of the successful mobilization with movement were delivered in each session. A self-applied mobilization with movement, mimicking the therapist technique, was taught to the subjects in the first treatment session. All subjects attended the clinic for 6 45 minutes treatment sessions carried out over 2 consecutive weeks. A physiotherapist blind to the treatment condition evaluated all outcomes at baseline, immediately post-treatment, 2 weeks, as well as at 3 and 6 months post-treatment. The primary outcome measure was the Western Ontario McMaster University Osteoarthritis Index score. The secondary outcome measures were the time required to complete the timed up-and-go test, knee range of motion, pain intensity over the past 24 hours, pain intensity while standing up from a sitting position, time taken to complete the 12-step stair test, and patient satisfaction with treatment. At each follow-up, including 6 months, significant differences were found between groups favoring those receiving mobilization with movement for all variables except knee mobility. The primary outcome disability showed a mean difference of 7.4 points, 95% confidence interval, 4.5 to 10.3, at 6 months, and a mean difference of 13.6 points, 95% confidence interval, 9.3 to 17.9, at 3 months follow-up. In this randomized clinical trial, subjects receiving mobilization with movement together with usual care showed significantly greater improvements in self-reported function, pain and patient satisfaction than those receiving usual care alone. This effect was apparent immediately after the intervention and was maintained even 6 months later. The greater pain reduction in the experimental group could be explained by modulation of pain through various mechanisms. Mobilization with movement may decrease nociceptive inputs while at the same time increasing non-nociceptive inputs via activation of peripheral mechanoreceptors. In addition, central mechanisms are involved as there is activation of the non-opioid mediated descending pain inhibitory system. Effects could also be mediated by altered output mechanisms, such as changes to muscle activation and behavioral mechanisms. Knee range of motion improved significantly following the intervention and at 3 months follow-up in both groups. However, there was no further improvement after this in the experimental group. A possible explanation could be that full range of motion, similar to the relatively unaffected knee, was achieved at the end of 3 months and the effects were sustained at final reassessment point. The experimental group regained full range of motion much earlier, suggesting a quicker time to recovery. For the timed up-and-go test and 12 steps test, the difference between experimental and control groups was evident only after 3 months. One explanation for this is that pain reduction achieved with mobilization with movement may not have been sufficient to achieve an immediate improvement in these functional activities. In conclusion, subjects with symptomatic knee osteoarthritis receiving 2 weeks of mobilization with movement in addition to usual care had significantly greater improvements than those receiving usual care alone. Beneficial effects were seen in disability, pain, function and patient satisfaction, and were sustained for 6 months.
For further information about the Mulligan concept, please explore our international website at www.mulligan.com.